Hi everyone, here we are. I'm talking 6 p.m. in Lisbon. This is a quite special session because this is absolutely a YouTube live session because we had uh, an issue the with the speaker and with his presentation. So we just want the show to go on, and here I am trying my best. Maybe I don't have that best look. My look is not the best, but in fact we didn't have that much sleep today because we are really focused on delivering the best experience and fantastic experience to you all. First of all, let me just thank you because it's great. The room is just fully booked, and I'm so sorry that so many of you could not enter. This is really awesome for us because this is the first thing that I would like to say to you. Thank you so much for the massive registration and massive implication into this project of ours. Also, I profit from this occasion to thank the speakers again for the fantastic lectures they have delivered so far and the ones that we will have further. Also, I would like to thank all the participants of the Facebook challenge, the Messenger challenge. We have over 1,000 participants in the challenge. You can still enter the challenge. You just need to go to your Facebook Messenger, enter the Facebook notifications just related to our Facebook page, and write challenge, and you immediately will receive all the indications and rules regarding this special feature that we have developed for you. Also, saying that we are very pleased to announce and very excited and happy to announce that we have now more than 10,000 participants and reaching very closely to 11,000. Sorry. And so let's go now to the presentation. I will present today a special presentation. I just prepared a few hours before because this is again I appreciate your understanding. This is an expected lecture. I just had this backup lecture that sometimes I lecture internationally around the subject of posterior teeth, and I just hope you like it. I hope I'll do my best, in fact, to keep up with the level of scientific knowledge that has been shared so far, and I really hope that you get the best out of this week because me and Rui, we really did our best to have everything together. So let's go. Of course, you know, my name is João Borda. I don't need to say that. I have a close relation with WIC University in Barcelona, the Universitat Internacional de Catalunya, with my mentors Luis Jané and Miguel Roig, that have throughout the years pushed me to be better and to do more. And I tried the best I can, and I will be and I'll keep on trying to do the best I can. Of course, I have the great partner with me, Rui and me. We just laugh a lot with these crazy ideas of ours, and of course it brings us also back to our family story and our family history. In fact, my family, I'm from Lisbon. I was born in Lisbon. I'm from Portugal, Lisbon, and but almost all my family comes from Madeira. It's a very small island. Maybe you've heard the Madeira wines, very good wines that are quite linked to England because English were very present in the island. And so Madeira Island was voted one of the best islands in the world, best island destinations in the world. So I really, really would recommend it to you. And in Madeira, I have two branches of the family, of course. I have the Borges branch that were entrepreneurs. And entrepreneurs means that they have done something very different at the time. And regarding the wine industry in 1877, my great-great-grandfather just launched the H.M. Borges company, wine company, that still exists, that is run by some cousins of mine. And it's great to see that, in fact, we just take a little bit that as an example to pursue some objectives in our lives, although some of them might seem impossible. As well, the other branch of my family is related to another entrepreneurship business that is still that still exists. Sorry. That is the sugarcane, also very present in that island, okay? And that sugarcane exists since 1883, and it's I don't know if it's available everywhere. I'm not sure, to be honest. This is my mother's branch, but anyway, I'm very pleased to say that I followed both businesses, and together with others, I knew that I would like to deliver something different throughout my life. And me and Rui, we are passionate about dentistry, as you know, and we just can't say no. And there's no cannot, there's no unwilling, there's no impossible, and there's no unsuccessful, because it's the passion and the work that you just put into things and into what you really, really believe that brings out the best of you. So I would say that this is the first message that I would like to send you. If you have any question regarding what you will be doing throughout your life, I think the best answer is to search inside yourself, or inside of who you are, and knowing that in fact there will be no boundaries to your development and to pursue your dreams, even though at first they might be, or they might be, it might seem quite impossible. In fact, I was quite touched by some students of mine I've just came across at Week University in, I would say, October, September, when I just met some students that had followed the International Aesthetic Masters 2015, the first edition, and that have been, in fact, pushed forward to pursue their dreams, to be better, to develop, to study, etc., etc., even though they come from very difficult countries such as Syria, such as Iraq, countries that have passed through so many difficulties. So they are just an example for me, and they might be an example as well for you. So there are no impossibles, and this also brings us to the fact that nowadays we have changed a lot, not only our profession, but the way that we can expect people to live throughout the years. Life expectancy has grown so much in the last 30-40 years that we need to focus on the preservation of tooth structures, the preservation of teeth, and the preservation of bone. So it means that, in fact, what we have learned, or what we have teach maybe 30-40 years, what we have teach maybe 30-40 years out of what is and will be the dentistry in the future. So when I say there's no impossible, is there's no impossibility of keeping a tooth or reconstructing a tooth or bringing the most you can technically to the preservation of that tooth and the preservation of that structure or the preservation of that bone. Of course, technically we have some new features and some new developments and some new techniques and some new materials that also allow us to get that better technical development. But anyway, this is one thing that you need to focus. There's a change on life expectancy. There's a change on that, and that is really, really important. So dentistry is now minimally invasive and also regenerative. It means that all the decisions we take, of course, as doctors, have a big responsibility, and even more knowing that you cannot block a second chance or a third chance to a situation inside that patient's mouth. So always take in consideration that your decision, your clinical decision, your treatment plan should focus on a second possibility or a third possibility. So be as most as you can conservative. Okay, so this is quite an example of the development. You see, in such a short period of time, we have come from the metal posts, the old metal posts that sometimes it's the only thing that you can use to treat teeth around the globe, because there's no other way, there's no materials. But of course you need to focus on searching them, and throughout this presentation I will try to develop through that in a way that you change a little bit the way of thinking, and you change a little bit the way you look at dentistry nowadays. Of course, after that we had the fiber post developments, a lot of fiber posts, and now we have the development of indirect restorations due to the big development of adhesion and adhesion techniques and adhesives that have developed so much in terms of adhesion resistance and adhesion final values. Okay, so the question mark is, what will be the next developments? And that is quite curious, because we have throughout the years we knew that, and we were taught to take in consideration the factor C. And the factor C is the cavity configuration factor. It means that it takes into consideration how many walls will be linked to the restorative material such as composite, and how many walls will be free. It means that you will have more contraction of the materials on factor C, a C factor, 5. It means that 5 walls will, like a class 1, a black class 1 restoration, and you have less C factor importance if you have, for instance, like a composite just placed over a buccal wall of a tooth, okay, because you have one wall just linked to the composite itself. So it's one wall to one wall, it will be C factor 1. In the contrary, you have C factor 5, the maximum that you can have. So that was the logic regarding the direct restorations. And regarding the indirect restorations, usually linked to the restoration of endodontically treated teeth or highly destroyed tooth structure, you also have the ferrule effect as something very important to consider. And the ferrule effect is the reminiscent of teeth, of tooth structure that goes from the limit that you have created for your crown, okay, the gingival limit, and the top of the tooth structure, okay, itself. So it means that, as Marco Ferrari studied, and in the literature review that you see on my left, okay, you can see that at least you need to have 1.5 millimeters of ferrule effect around the all tooth, okay, and that an incomplete ferrule effect is better than a no ferrule effect, and also that when you don't have ferrule effect, you need either orthodontic extrusion or crown lengthening. Orthodontic extrusion for the anterior teeth to create a wider and bigger length of structure that will be over the gingival area, and not changing, of course, the gingival contour of the anterior teeth. And the posterior teeth, you could consider some crown lengthening, okay? So these were, I would say, were the concepts that we considered while studying some years ago. But nowadays, changing the slide, we have here, changing the slide, we have here the development of new composites, okay? And the new composites are the bulk fill composites. That are composites that don't have that much shrinkage, that don't have polymerization contraction, and so they just tend to change a little bit the C factor importance, and they just are filled as a whole. You don't need to stratify inside the class 1 cavity to diminish the importance of that contraction and of that polymerization contraction together regarding the walls of that tooth. Okay, these are the articles, the new articles in 2016 of the bulk fill restorations. Of course, I'll be more than happy and pleased to share with you all the articles of this presentation. If you want, you just comment below if you want your email, okay, and also comment as well how much you are getting this aesthetic masters into your life, and if you are having fun, if you are having a good experience. The comment bar is also for that, to exchange with us, and we will try the most we can to get back to you, even though we are busy. You are, in fact, our connection the most we can, okay? Also regarding that was regarding the C factor, and now related to the ferrule effect, the new articles and developments and new investigations from Pascal Magne are articles very, very interesting, because they consider the no post, the really no post and no ferrule in the rehabilitation of posterior teeth. So it's a big change, don't you think? It's really incredible, because we have come from a position in which the ferrule effect is important to maybe a position in which you don't consider that. So let's just go through that, and through the cautions that you need to take care and to take in consideration, and to keep in mind before you treat the patients, okay? Of course, Professor McGann is one of my references, one of my mentors, that is someone that has all through my professional path has been an inspiration. And this is a slide that I show almost always in my presentations, because he's absolutely right. Let the knowledge and not the trend of the moment be the guides of your hands. And in fact, this is so important that my presentation is not about technique. You'll see so many presentations throughout this week about technical aspects, how you'll do, etc. This is more about how can you be successful on the treatment of posterior teeth, meaning what should you think, what should you have in mind when you comes to the moment you need to do the treatment plan of that specific tooth or that dentition, okay? And so keep focus on that. Keep focus that we really need to get that in place, okay? Of course, don't forget that we have time against us, I would say. It means that all that we do is always quite difficult to be as good as the natural. Okay, we will try to get the most, the closer possible to the natural and to the natural quality of the dentition, but we need to decide on treatment plans that have a long-lasting effect on the life of the patients and on the life and the survival rate of that tooth or of that dentition. Okay, so just take a look at this case. This is a 1.6, okay, that was restored with that was treated endodontically and then restored with composite restoration just on the occlusal area, and just take this in consideration. The patient comes to my practice, to my clinic, and he comes with a tooth and a big crack, a catastrophic crack, meaning that I need to extract. What happened here? In fact, what happens is you have a resistant arch that goes around the cusps and the marginal the crests, okay? That will be like the strong resistant arch and resistant area that keeps up the linkage between the force, the occlusal masticatory force, and as well the resilience and resistance of the tooth. So when you look at the tooth like this one, you cannot consider only the restoration. You need to consider the contact of this tooth, the lateral movements of this tooth, the function. Nothing is more important than the function. And in posterior teeth, it's not only maximum intercuspidation, it's of course lateral movements. This is very important. So take a look at the composite restoration. Sorry, let me go back. Just take a look at the composite restoration. The composite restorations almost fills up all the inside of the resistant arch. It means that the walls, the buccal walls, the palatal walls, the walls inside the crest are just free because there's an endodontic treatment that was done. There's a big lack of dentin inside. There's a non-linkage between the buccal walls and the palatal walls. They are like alone and not linked together. So there's a lack of resistance. So the fact that the tooth is endodontically treated, it doesn't mean it has lost resistance. It has lost resistance because mechanically it has changed, okay? So what should have been done here? You should have considered the function and the lateral movement that in this specific case with group function and group function over that buccal wall just gave an eccentric force too heavy for that buccal cusps, and you have a crack, okay? So this lack of resistance and lack of linkage between the walls means that you need to go for an indirect restoration and a cusp coverage, meaning in this case, I would say this specific case, I would say an overlay, okay? An overlay that will allow the regaining of a mechanical resistance, a regaining of a resilience, and of course the protection of this tooth. But on the other hand, if you evaluate a case like this one, the patient wanted, this was like 11 years ago, the patient had the need for an endodontic treatment and just wanted a direct composite, and at that time there was like a trend on placing fiber posts, okay, and nowadays I just place very little fiber posts a year. I would say like 5-6. Not that I don't work, of course I'm a clinician like you are, but things have really changed in the way we look at teeth and function are different. So of course this tooth didn't have a problem the patient didn't want to follow the treatment, didn't want to follow for an overlay, etc. And what you can see here is, of course, some marginal gap and marginal infiltration after 11 years, but quite stable, quite stabilized, because you have a posterior and an anterior tooth, and you should also consider the collateral protection of each tooth and each restoration that you will perform. The patient came, of course, for the treatment of a secondary caries underneath the composite mesial restoration on tooth 26. Okay, so the success will be related more to planning, in my opinion, not with materials and methods, because or the technique, because in fact what you need to consider is, if I do not plan correctly, it's not my material that will do the thing. It will not be the technique, even though you'll have the best technique possible. The planning is the moment. The planning is always related to function. Okay? Always take that in consideration. So if we just see the different points that you need to consider for the success of the restoration of posterior teeth, I would say the first one to be the individual biomechanics. Okay? Individual biomechanics means you are deciding, you are taking the decision on which restoration, which treatment plan will I perform in this tooth. You need to know which regular and usual anatomy do you have. Is it a premolar, an upper premolar, a lower premolar, a first, a second premolar? Is it a first molar, a second molar? The anatomical situation is absolutely different, so you need to consider differently. Of course, when you have a first molar, you have two buccal, first upper molar, sorry, you have two buccal roots and one palatal root. So it means that that tooth by itself is mechanically, on the deflection forces, is more protected than maybe a second premolar with bifurcation of the root on the apical third. Because if you give an excess of force, a surcharge, an occlusal surcharge over that second premolar, maybe what you will have, of course, is a big risk of fracture, okay? If you don't have, for instance, like the posterior teeth. So anatomically, you need to consider, oh, okay, I'm treating a first molar. Okay, the first molar, maybe you will have more vertical contacts. You won't have more lateral contacts. But maybe the premolar, the first upper premolar, if it comes closer to the canine guidance, if you have a canine guidance, group guidance given by the canine and first premolar, the deflection movements will be very strong. So the anatomical situation can play a role on the success rate of this treatment and of course, the long lasting success of your treatment and the preservation of that specific tooth. So take this in consideration. You have a case like this one. As you see on your right, you have a ceramic crown, a metal ceramic crown, and the patient comes with an history of several decimentations of this crown, okay? So it means that you have somehow a mechanical problem. Somehow, somewhere, because it's not normal, okay? The patient comes in an emergency and he says, I just want to hear your advice, I have pain. And so the first thing you see is first premolar. You know that you might have some deflection on the occlusal forces and on the lateral movements. And worse than that, you see that the ceramic has fractured. So it means that somehow, at some point, there was an excessive force over this tooth. And when you take out the crown, what you see is a metal ceramic crown with metal posts inside a lack of a rule and an occlusal surcharge, okay, and you see, of course, a longitudinal fracture of the buccal root. And when you take out the crown, just going through this slide, when you go take out the crown, you see that the adaptation is not good, okay? And of course, following, you need to take the decision and take out the root, because it has been like 15 days that the patient has pain, no answer to that, and so you need to have, like in this case, the fracture of this tooth and the fracture of this root gave the need for an extraction of this one, okay? So it's not the same to speak about the premolar than to speak about a molar, okay? And a molar such as the lower molar, you have like an excess of enamel, as you can see by this super article from Pascal Magne and Panos Bazos. This is a great article that I always talk about. And in this article, you can see that the anatomy of this molar has a big volume of enamel on the buccal cusps to allow the occlusal force to be applied without any problem whatsoever regarding the mechanical. So going to point number 2, so the first is individual mechanics, and the point number 2 will be the integrated mechanics or the general biomechanics. It means that not only you need to focus your decision of the treatment plan regarding which tooth are you treating, as you need as well to look at that tooth in the general environment is integrated, okay? Because you have the vertical occlusion, you have the lateral occlusion, you have, of course, lateral movement, you have the protrusion, you have the retrusion. It's a dynamic environment. And all the pieces of the puzzle have that environment and need to be adapted to that environment. Of course, you need to add other factors such as the muscles, such as the TMJ, such as all the aspects that can keep the balance of the system in place, okay? So look at this tooth. This tooth, normally, this is an endodontical treated tooth, and it's a 3.6, and this 3.6 normally for that case I would consider maybe an overlay regarding the flexibility, the flexibility of the mesial vestibular cusp and the lingual vestibular the lingual mesial cusp. Sorry, it means that in this case I didn't do that because I evaluated the function, and evaluating the function, I could see that I had a stable, as you see in this slide, a stable canine guidance. A canine guidance that would give me a disocclusion of the posterior regions in the lateral movement, either the right or the left lateral movement, so protecting all the restoration and protecting the tooth itself. This is a follow-up, a 5 years follow-up of a Emax onlay, okay, and you can see it's quite stable, quite okay, and the patient is okay and having a normal masticatory function over this tooth, okay? If we go for this case, you can also have different cases, functional cases, and quite big cases, maxillary cases, in which of course you have the rise of the vertical dimension, and here comes into place the muscles and the TMJ. You need to have and to get an adaptation of that of the muscles and the TMJ to the new situation. So sometimes if you have a rise, you need to rise the vertical dimension. Of course, you need to leave in place a mock-up or a provisional that creates a time of adaptation before the final restoration, okay? In this case, changing to another slide, you can see that we have restored the lower jaw and the upper jaw with minimally invasive restorations, veneers on the anterior teeth, and veneer lays on the premolars and overlays on the molars. Okay, and this way, with the rise of vertical dimension and 4 years follow-up, we have kept in place a good restorative procedure and a good rehabilitation for this patient. Okay, this is also very important. Don't rush. You cannot rush treatments. Okay, you need to take time for your treatments, and the more difficult are the treatments, the more time you need to do them. Okay, the quickest you go, the quickest you have problems. Okay, and you need to focus your attention and your work on the long lasting and the preservation of your profession abilities and profession skills. Okay, so point 3, going to point 3, we have talked about individual mechanics, integrated or general biomechanics, and now point 3 will be the reminiscent to structure. Either you have a good quantity of tooth structure, and so normally you will go for direct restoration, or you don't have that and you need to consider indirect restoration. It doesn't mean that you need to consider ceramic or a lab work, because you have so many possibilities. You can even use lab composites, or you can even use your composites, okay, and give an extra polymerization. But what you cannot avoid or you cannot miss, of course, is this evaluation of the mechanics, this evaluation of the function, and of course this evaluation of the outcome of this work. Okay, so this is the reminiscent to structure, direct or indirect. Continuing this presentation, you can see this class 1 on a 1.6. This is a caries lesion that when you prepare it and you prepare the cavity, you need to keep in mind that you need to keep the most you can the marginal crests, and you need to keep also in mind the linkage between the buccal distal cusp and the mesiolingual cusp. Okay, because that quantity of enamel and dentin is really important. Okay, it will keep up the mechanics around this tooth, but as well as in this one. Okay, this is a very important article. Okay, this is an article of 1989 about the reduction in tooth stiffness as a result of endodontic or restorative procedures. And what he found out was that if you lose in a premolar, if you lose the marginal crest, one marginal crest, you will be losing 46% of the mechanical properties of this tooth. Can you imagine one marginal crest? A simple class 2 direct restoration. So when I say be conservative, is at this point. Okay, and if we go further, you have when you have like 2 marginal crests that are lost, you are over 60%. So it means that mechanically the tooth natural resistance that he had. Okay, so natural and the natural resistance that he had. Okay, so this is one of the aspects that I need you to focus. Also focus that if you lack dentin, if you have an endodontic treatment, you have more problems. You have more problems regarding the So going further, take a look at the natural mechanical properties of this tooth. So going further, take a look at this one. This is a case of 25-year-old amalgam restoration, MOD amalgam restoration. And what we can see is some vertical lines, vertical cracks on the buccal wall and on the palatal wall, of course this tooth was in place, still in place, because it's preserved by the molar and is preserved by the premolar. But if I need to consider a restoration of this tooth and taking out the amalgam, what I will have is the lack of resistance. So I cannot restore as it was restored with amalgam in this specific case, because the micro cracks that I can see on the buccal and palatal wall can develop and can create a real crack. So in this case, this tooth is a candidate to the indirect restoration with using an overlay, okay? As of course you have in this case a cusp fracture, a possibility of cusp fracture also in the, if you consider the restoration a direct restoration with composite, with not using bulk fill but using a big amount of direct composite that will shrink, that will have polymerization contraction, and that will change everything, and so on and so on. Okay, so look at this restoration. This is a non-endodontically treated tooth, but it fractures as well. So what you have is a composite restoration, and you have the fracture of the mesiolingual cusp. And why is that? Just because when you look at the tooth and you do not consider the function, the patient comes with this emergency with no anatomy whatsoever in this restoration, but most of all with an overload on that cusp. So the cusp is like standing alone, just with some adhesion and some adhered to the composite, but it is standing alone, okay? So if you have an overload of this cusp, the probability of creating some micro cracks on the horizontal area near to the gingival area or the vertical cracks is great. So it might fracture as you have here, because if you take a look, just going through the resistant arch, you can see that the composite just goes over and outside the resistant arch, okay? Let's see now this example and this fourth point. We have seen individual biomechanics, we have seen also integrated biomechanics, and we have seen as well reminiscent structure. Now let's take a look at the materials. How much do the materials influence your decision? Of course, you have composite, you have reinforced polymers, and you have ceramics. How to choose? Well, in fact, going through this article, you can understand, and going back to the article of Pascal Maia and Panos Bazos, you can also understand that if you take out the enamel on this histoanatomic approach, you take out the enamel and you keep the dentin, you see that the dentin is not absolutely convex, it is concave. And it has, if you read carefully the article, you can understand that the teeth have a big amount of enamel that will just take the force, and then all the dentin that will sustain the force. So you have like a linkage between these two structures, that is the internal enamel layer, that is the dentin enamel junction, and the dentin mantle. Altogether, this dentin complex will form what is called like the resilience arch of the tooth. So it means that if you go further and if you lose this dentin mantle, and if you lose that dentin enamel junction, and if you lose this linkage to the enamel, you are losing mechanical dentin to a force that cannot be sustained, because the enamel is the most mineralized tissue in the body, and it sustains the first force, okay? So the logic is this one. If you have enamel, you are not changing the mechanical properties of the tooth. But if you do not have enamel, and you only have dentin, you are changing the resilience and the mechanical properties of the tooth. If you lack enamel on the pulp chamber, as in an endodontic procedure, you are also changing, because you are changing the linkage between the walls, and you are changing mechanical properties around this internal area of this tooth. So it means that going further this presentation, just take a look at this case. This case was performed by me and Rui. Rui is one of the best endodontists that I've worked with, and maybe one of the best in the planet. Of course, there is my friend, but I need to say this. And is a solving problems guy. If you want to say hi to Rui, place the comment below as well. So this was an endodontic treated premolar, upper premolar, that we used to work together in the clinical team. So what we did was a pre-endo restoration with isolation, of course, always isolation, please. And then we performed the endodontic treatment. And don't forget, before you take out the provisional material, such as cavite in this case, please isolate again, because it's not logical. If you isolate for the preservation of the sealing of the tooth and the preservation of all the bacteria outside, of course, when you take out, you need also to preserve this environment. Okay, so I took out the previous endo restoration, and I started, as you see in this next slide, I just isolated and just did a deep marginal elevation. Okay, I did a deep marginal elevation. In this case, I used the OptiBond FL adhesive, but as you know, now you can have also you can use another type of adhesives as universal adhesive using selective etching. Okay, so as you can see here, we do a build up, we rise the marginal area, and we finish with a preparation for an overlay. In this case, is a second premolar. An occlusal surcharge, and and in this case, as it is, and it was an endodontically treated tooth with an occlusal surcharge, and I wanted to get back to the mechanical properties of this case, I rehabilitated with composite polymers in CAD-CAM material that is stained as well. Dynamic is a CAD-CAM material that is stained as well. CAD-CAM material that is stained as well. That can also be related with some plastic properties of the composite, and also some properties of the ceramic mainly regarding the wear and the conservation of the structure without any change whatsoever. So I isolate, I use in this case heated composite for the cementation of this indirect restoration, this indirect overlay. Marco Gresnik will talk this Friday about this, and please do not miss this presentation because it's absolutely great. Very, very scientific, high level, of course, all of the lectures. We are very, very happy, pleased and honored to have them, because the quality of the science is extremely, extremely high. And so, as you see, we have a good result. But this is the way you treat a tooth that has lost mechanical properties. It has lost mechanical properties, so you need to get back to the plastic properties. And sometimes, if you have lost this mantle, if you have lost all this dynamic around this dentin enamel complex, then you need to restore with a more plastic material. It's valid that you use a composite polymers, as it is to use a composite itself, a laboratory composite that you yourself, you can do it during your lunchtime with some laboratory composites. You can practice your anatomy and use polymerization, how you say, box, polymerization box. Sorry, sometimes the terminology might not be here in place, because as I said, this wasn't planned, this wasn't programmed, so I'm really doing here my best. I'm very sorry for that. So this is the case in which you have loss. But if you have a case of erosion, with some rise of vertical dimensions such as this one, as you see in this slide, you have as well the possibility of restore. And you need to restore and have in mind that you have not a change of mechanical properties, you have not a change of plastic resilience and function of the dentin enamel complex. You have everything. The tooth is almost intact. What you have lost is some enamel. So in this case, the adhesive cementation will promote the plasticity and will promote the resilience and more resilience of the tooth, but the basic resilience hasn't been lost. So you can restore with some ceramic materials, such as this one is a lithium disilicate and IMAX restoration from Ivoclar Vivadent. So as you see, you have individual. I go back because repeating is, as Louis Janet says, repeating is the way to learn. So the first thing is individual biomechanics. The second thing, generalized and general or functional biomechanics. 3, reminiscent structure. 4, materials. What to decide whether you have dentin enamel complex present or you don't have. And just to finish this part, just to say, if you have a veneer, buccal veneer to place, a non-prep buccal veneer that is only valid when you have, in my opinion, an absolutely non-prep is that one restoration in which you don't have the correct form, you have a lack of form, you have like a microdent, and you just can adhere ceramic over it. And in this case, there's no change of the structure. The structure is exactly the same. So you can also use ceramic veneers. Of course, ceramic veneers are also in place in other situations whatsoever, like, for instance, situations of an aesthetic change. But function needs always to be our guide. Function is first. Function is first. Okay? And so we come to the end of this presentation, and we talk about the 5th point that can lead you to the success of the restoration of posterior teeth. And this one is related to the technical aspects. You see, a lot of courses that you might have attended are related to the technical aspects. And in fact, I must say, after almost 15 years of lecturing and giving classes, etc., the most difficult thing to teach is how to plan, how to think, how to decide whether you go this way or that way, which tooth comes first on the decision, which tooth is to be treated first, how can I go through the whole rehabilitation. And this is, in my opinion, what will be the focus in the next years, because the technical aspects, the more you practice, the more you get it. And I'm sure that if you are focused in aesthetic dentistry and going further, you will practice, and you will practice a lot. Okay? So in this case, the technical aspects come into the evaluation of the dentin just underneath the cusps. In this case, we performed the build-up, and after the build-up, this was a crossbite and the occlusal force were on the buccal cusps, and so to diminish the risk, to diminish the occlusal overload over these cusps, I really decided to go for cusp coverage. But as the palatal cusps didn't have contact, and neither on maximum intercuspidation nor on the lateral movements, I decided to keep it this way. So be conservative and keep up this thing in mind, okay? So we go through this case, and just to check that sometimes what we feel, what we think, can also be adapted. As in this case, just technically, how will you do, how you need to do? Well, you have 35-year-old amalgam restoration, okay, and the patient, you have some infiltration, and so you just plan the substitution using and treating with inlay restorations, okay? Is it possible? Is it possible in this case? Well, you have vital teeth, you have stable occlusion, and you can copy the exact occlusion that was related to these amalgam restorations and have exactly the same for the inlay restorations. What you need to focus, and again I say this, is on occlusion and function on the prior evaluation of your case. Okay, diagnosis, and treatment planning, and then you just go and you do your thing. Okay, so just getting through this case, you see, we prepare first. I take out all the amalgam restorations using isolation, of course, to avoid the dispersion of the mercurial. And in this case, after I've prepared and I've exposed the dentin, I just perform the immediate dentin sealing. Okay, the immediate dentin sealing is a procedure first described by Pascal Magnet in 1999. Of course, there's lots of new nomina, new ways of saying it, but what it does is an hybridization, first hybridization of the dentin, that in this case was done with OptiBond FL, a total etch 3-step adhesive that I used quite often. I still do, but nowadays we have come to the conclusion that some other adhesives have better behaviors regarding the dentin, such as the self-etch adhesives that have the molecule 10 MDP present not only on the clear fill SE adhesive, as in most of the universal adhesives that have recently been launched in the market, such as Scotch Bond Universal, Adhese, and many others. Okay, so in this case, I do the etching only on the dentin, and then I wash. Of course, the dentin is to be etched 15 seconds, and then I apply the primer. Don't forget that the primer of the total etch 3-step is to be applied the double of the time of the etching, and in big quantity to have a good impregnation inside to perform then the resin tags and to perform a good hybrid layer at the end. So as you see here, you have not only the immediate dentin sealing, as you see, you have also a build-up underneath the buccal cusps of the 1.6, also because I would like to take out all the retentions that I have that for a better setting, a better adaptation of my indirect restoration. Okay, after this, after I cure, I take out the rubber dam, of course, and I do either regular analogical impression, or I do a digital impression with the scanners that are available now. Afterwards, we have the laboratory just performing, in this case, the Emax indirect restorations. And so I go again, I take out the provisional restorations, and I do the try-in. I go and I isolate again. I do the try-in of these restorations. Then I do aluminum oxide cojet over the immediate tendon sealing area, just to activate again this resin. Then I etch the enamel, and then apply a new layer of bond all together. But keep in mind that this layer of bond needs to be very, very, very thin, because if it's not that way, you will not be able to place that indirect restoration into its correct position, and you'll have a problem. Okay, so don't forget that. And so we finish with the cementation of this case. Okay, and of course after some years we just go for maintenance every 6 months, and we check the restorations if we have to polish or if you have to check anything else. And so in this case we have 3 years, in fact it's a little bit more, 3.5 years follow-up. And you can see the stability of these restorations, the stability of the contact points. And in this specific case, we didn't perform direct restorations because we wanted to keep and enhance the interproximal contacts and to have everything together. Okay, so finishing this lecture, for me, first of all, leave your comments, profit from this week. We've worked very hard, and the speakers worked very hard to deliver a fantastic experience to everyone. We are more than happy, we are thrilled and excited to have more than 10,000 participants in this Congress. Share this event, share with everyone you know, with your colleagues, with your friends at university. Post in Facebook, where are you watching, either at university, at home, at your clinic. We really want that, because this is the way we can interact and we can understand how much this event means to the people. Of course, you will follow now with several other presentations still to come that I am absolutely sure that you will enjoy. Don't forget to activate your Facebook notifications. Don't forget to, if you want, of course, to write challenge, to be one of the participants that are into this challenge that we have come up. And so this was a great pleasure for me. I'm sorry if it wasn't sometimes exactly the way you might have expected, but I did my best. I did my best in short notice and short time. I really hope you've enjoyed it. But don't forget, diagnosis, function, really, really, really important. Not only maximum intercuspidation, as well lateral movements and protrusion. Don't forget to plan and do a correct treatment plan related to the function, and then go through the decision on materials and techniques that can allow you a long lasting of your treatment. Okay, use isolation, as Stéphane Brouet talked this morning. Very important, please, because material are very, very sensible to that as well. Just wrapping up this presentation, first you look at which tooth are you treating, individual biomechanics, is it a premolar or molar? Second, integrated biomechanics, how is it related to the other collateral teeth or the opponent teeth? How is the muscles? Is it a brachiofacial patient, a dolichofacial patient? How is the TMJ? Do you have pain? Does the patient have pain or not? Okay, so integrated biomechanics. Then after looking at all of this, you just take a look at reminiscent structure and you decide either you can go direct or you go indirect restoration. You decide on the materials. Either you have dentin enamel complex, so you have plasticity, you have resilience, and you keep it up with ceramic or composite polymers, okay? Or you don't have that and you need to go for softer materials such as composite polymers or composite itself. And you finish with techniques that enhance your practice and that keep you up with a good job, and you keep it up with a good work. And I finish with this video, okay, that I hope you like. This is my email, my personal email.